Hello students, I'm here to walk you through a newborn head to toe assessment. Let's first go through normal vital signs on a newborn. So for temperature, we would expect the baby to be your normal 98.6. If you find a baby that is below 97.8, you will see them put them under a warmer to raise their temperature. We will talk a little bit about normothermia of the newborn in class, so you'll learn more about that, but just be aware that if your baby's temperature is below 97.8, we would expect to put them under a warmer to help raise their temperature. For heart rate, normal heart rate is 110 to 160, and you would want to listen to the baby's heart rate for a full minute with your stethoscope. And then for respiratory rate, we would expect it to be between 20 and 60. When it comes to blood pressures, we do not do blood pressures regularly on the newborn, as well as pulse oxes. We do not do them regularly on the newborn, but you will see them do pulse oxes once the baby has hit 24 hours old, and we would expect their pulse ox to be 94% or higher when taken. So the first thing we can do is just count a respiratory rate. We would look for chest rise. You can also put your hand on the baby's chest and abdomen to kind of feel the respiratory rate. I really like to listen to the baby's respiratory rate. I find that it can be easier for me to count it when I'm auscultating it, but you will see some people putting their hands on the baby to feel it as well. So as I said, we would listen for the heart rate for a complete minute through the apical, and we expect between 110 and 120. And then at this time, you would flip to the other side to listen to the respiratory rate if you are listening versus visually seeing or placing your hand on the baby. The biggest thing when you're auscultating for your heart rate, and if you're auscultating for respiratory rate, is to try to keep yourself focused. It is very fast, so a heart rate of 110 to 160 is very fast to count, and you can lose track, and it is okay if you have to count it a couple of times. It does take some practice. So after we get our vital signs, the biggest thing I always say is you want to take your baby and draw an imaginary line down the center of the baby. When you're looking at your infant, everything should be symmetrical. So whatever you see on the left side of the newborn's body should be the same thing you see on the right side. So this is where you're looking at your eyes, making sure that they are in line, your ears as well, that they're not low set, that they're in line. You're looking to see if maybe you see any birthmarks or any bumps or growths or anything that may be on one side of the body versus the other. Those are all abnormal findings that we would want to make sure that we mark down. So as we're looking at the infant's head, you would just gently cradle the baby's head in your hands, and what we're going to feel for is a couple of things. First thing, you want to palpate the infant's fontanelles, and we have the anterior fontanelle right here in the front. It is kind of, in essence, an odd diamond shape, and that stays open on an infant until they're about 12 to 18 months. So you would expect to palpate that on your newborn. What you want to see is that your fontanelle is soft and flat. If it is sunken in, we worry about the baby being dehydrated. If it is bulging, so it's not level and it feels like it's popping out, we're worrying about increased intracranial pressure on the infant. The other fontanelle you'll have is your posterior fontanelle. It is in the back of the baby's head, and it feels more like a triangle, and it is smaller than the anterior fontanelle. It does close much sooner. At roughly about 4 to 6 months, you'll find that it will close, and you're just seeing the same thing. Is it soft and flat? And all you're doing is gently running your hand over the area. You're not actually pressing into it or anything, but you should be able to gently rub your hand over it and see that it's soft and flat. The other thing that you are checking for when you are feeling the baby's head is we're checking for suture lines. So your babies can have molding. So currently, until the fontanelles are closed, your baby's sutures aren't completely fused together. It allows for the brain to have room to grow, and so those suture lines can be slightly mobile, and that's what can cause the baby to have what's called molding, or you might see it also known as like cone head. So the shape may look funny. What you're feeling for is where the bones meet on the skull. What do they feel like? They can be in a line, so they just kind of, you can feel them, but they feel flat and put together, so approximate. They can also be overriding, where you can maybe sometimes feel one of the bones over top of the other, and that would be usually experiencing where you're seeing molding. And that's all you're feeling for. We want to document if we find that. It's not anything abnormal or concerning unless we don't see that the baby's head goes back to its normal shape. The other thing you're looking for is what's called a cephalohematoma or caput cecidium. So when it comes to that, they are enlarged bumps that you will feel. So your cephalohematoma doesn't cross suture lines, so it's going to be one-sided, either on the left side or the right side of the baby's head. It is going to feel hard, and it's actually broken blood vessels in the scalp, so it is going to be more hard in its feeling when you palpate it. Caput cecidium is swelling of the scalp itself. It feels kind of spongy, and it can cross suture lines. So you will see it cover more than one part of the baby's head, so it will go from the left side to the right. And like I said, it feels spongy. It doesn't feel hard like you would see a cephalohematoma. Those are very common things that can happen in the birthing process, so they aren't anything that's major concerning, but something we do document, so you would want to notice that. As we continue on the head, the other thing you will check, you would want to make sure you have gloves on, and we would check for the sucking reflex as well as for the baby's palate if it's intact. So you would just take your pinky, make sure you have gloves on, and you would palpate the roof of the baby's mouth. You are checking to see that it's intact, that you don't have any type of cleft palate. You can visibly see a cleft lip. We're checking for that. And then also while your pinky's in the baby's mouth, you'll notice if they have a sucking reflex that we're checking for. So then as you're continuing on, the other thing you can check for, the other reflex that we check for is the sucking reflex, or excuse me, the rooting reflex. So you could just gently brush either cheek, and what you should notice is the newborn, if I gently stroke this cheek, it would slowly turn towards you, and that's what you would expect if they have a positive rooting reflex. As we continue on, we're going to palpate the baby's clavicles, make sure that they're intact. We can have birth trauma where they can be broken, and you may feel like crepitus, like that snap, crackle, pop feeling, and those would be all abnormal findings that you would want to note, but what we just want to feel is that they feel intact. As we're continuing on, you want to listen to lung sounds now. So we kind of did our respiratory rate, but we just want to listen to make sure they sound clear. Depending on the size of the infant, you may have anywhere from 4 to 6 spots that you can listen to on the chest. It does depend on the size of the infant. And then you can easily roll the newborn to the other side to get the posterior. Immediately after birth, you may hear a little bit of moist lung sounds. That's not exactly the most abnormal. If you have a baby that has any amniotic fluid still in there, we want to make sure that you start to hear clear lung sounds as they progress. But like I said, if they're brand new, it's not very uncommon to hear a little bit. When you are auscultating your heart tones, you may hear a murmur potentially. We note if we hear any murmurs in our infants, but a lot of them can be benign, and it's because we have fetal circulation that turns into newborn circulation, and during fetal circulation you have certain holes that are in your heart, and that are open and they will close after your baby takes their first couple breaths, but sometimes they don't, and they aren't major concerning unless we notice that the baby is symptomatic and having other things. So the baby is cyanotic and having those other issues, or having issues keeping their heart rate up or keeping it within normal range. So it's something we note, but not necessarily we are horribly concerned with, but you will always see them investigate any murmur that is found just to make sure that it isn't something else versus just maybe a benign murmur. While you are listening, this is also a good time. You always want to look at circulation color best on the chest and abdomen, because especially because of birth trauma, your infant could have a lot of bruising on the face, and it could potentially look like maybe they're cyanotic on the face when really they aren't. Or you can have what's called acrocyanosis, where their hands and their feet are blue in color, whereas their central is pink. And that is a normal finding as well on a newborn, just because of immature circulation. We do note if the newborn has what's called acrocyanosis, but it's not something that we're concerned with. And then, so we're looking just to make sure the infant looks nice and pink. And then you'll also just palpate the abdomen, make sure that it doesn't feel distended in any way. You will look at your newborn's umbilical cord. Depending on the age of the newborn, it's either going to be what is called moist or dry, and it just depends. They don't really put anything on the newborn's umbilical cords anymore other than the cord clamp to keep it closed. And outside of that, it's just going to do the natural drying process. Once it's fully dry, you'll see them take the cord clamp off. But we're just checking to make sure that we don't see any redness. Anything that would be an indicator of an infection of that umbilical cord is what you're looking for. So think of what you would look for on an infected wound. That's what you're looking for when it comes to the umbilical cord. As we continue on, like I said, we're continuing to look for symmetry. On the upper body, you can put your finger in the baby's palm, and we're checking for the palmar grasp at this point to make sure that the baby is able to do that. You can do your normal range of motion, just make sure that the baby's limbs are moving. One of the other things that you would check is the diaper area, what we're looking for. So for the GU system, your infant should urinate and have its first bowel movement within the first 24 hours of age. If one of those does not occur, that is something that would be considered an abnormal finding that we would report. And the first stool that the infant has is what's called meconium. It's black and tarry, very thick. Usually they have a couple like that. But like I said, we want to make sure that they have their first urination and bowel movement within that 24 hours. The other thing you're looking for is symmetry of the reproductive organs. So we have a little girl here. Normal, or I should say, findings that we would document but wouldn't be concerned with is you could potentially have labial swelling. That is not abnormal, especially if you have a breastfeeding mom. A little girl can have some labial swelling. They can also have a little bit of vaginal discharge, just from the hormones passing from mom to baby when breastfeeding. And we would document it, but not anything we would be concerned with. With a little boy, you're going to feel for descended testicles. So you would basically hold one side of the infant's scrotum, and you would palpate for the testy on the other side. Once you locate it, you would just gently hold it, and then you're going to palpate for the testy on the other side. If you don't gently hold the one testicle, you may bounce it from one side to the other and think you're palpating two, when really you're only palpating one. So you want to make sure that you palpate both testicles. Sometimes newborns can have undescended testicles where they're kind of stuck in the inguinal canal, and we need to keep track of that because that can cause the infant to have sterility issues later if they don't descend. So that's the one thing we're really looking at. So after you check that part of the diaper area, the other thing on the back side you would want to check for, you can gently turn your infant on the other side, and what we're looking for, I know this, my baby here has a zipper, but what we're looking for is, do you see like what's called like a sacral dimple? And we would document if we see that the spinal cord is out of alignment in any way, or if you see any dimpling in that coccyx sacral area, because that could be a potential issue with the spinal cord. It may be nothing and may just be that baby, but we do document that, and they will do further investigation. So we're going to put our diaper back on. Like I said, you would make sure you would be wearing gloves while you are touching your baby in the diaper area. All newborns at our hospital at Firelands do not get baths for 24 hours old, so you would want to make sure that you are wearing gloves at all times when you are caring for any infant that is younger than 24 hours old and hasn't had their first bath, no matter what kind of care you're doing, whether it's just feeding them or holding them. And then once they've had their first bath, it would go to the normal PPE standards when you are doing anything with any bodily secretions. So then on the legs, we are just checking for normal range of motion. This would be also where you could do your Babinski reflex. We're looking for fanning of those toes, and you would document that. One thing I did forget to mention previously, when we were talking about potential swelling of the labia, you may also see that a little bit of breast development that can occur on females and males. So little boys and little girls can both get a little bit of breast development related to breastfeeding potentially. Outside of that, I think we have covered everything related to your normal head to toe assessment. I know when we were talking about palpating the baby's abdomen, I didn't mention auscultating their bowel sounds. You would of course do that. But I did try to make sure I highlighted all the different things that we would want to expect to find on our newborn assessment. So we will see you in OB. Enjoy your wonderful year.